a 52-year-old female presents with progressive, severe dyspnea and a dry cough. I am showing you a frontal chest radiograph and an axial high-resolution chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates diffuse reticulonodular and linear opacities, prominent curly B lines, and bilateral pleural effusions. The axial high-resolution computed tomography scan reveals marked, nodular thickening of the interlobular septa and the central bronchovascular bundles, outlining prominent polygonal structures of secondary pulmonary lobules. There is also nodular thickening along the major fissures. The underlying lung architecture is completely preserved, with no honeycombing or traction bronchiectasis.
Based on these imaging findings, what is your primary diagnosis and the key pathological process?
The primary diagnosis is pulmonary lymphangitic carcinomatosis. The key pathological process is the infiltration and growth of tumor cells within the pulmonary lymphatic channels, accompanied by local desmoplastic reaction and interstitial edema.
If I tell you the patient has a history of treated breast cancer and is currently receiving adjuvant chemotherapy, how does this clinical history guide your diagnosis?
This clinical history strongly supports lymphangitic carcinomatosis. In a cancer patient, these high-resolution computed tomography features of nodular septal thickening with preserved lung architecture are virtually diagnostic of lymphangitic spread, rather than atypical infection or chemotherapy-induced toxicity.
What are the 3 most common diagnoses to consider when a cancer patient on chemotherapy presents with diffuse reticulonodular opacities on a chest radiograph?
The 3 major differentials are pulmonary lymphangitic carcinomatosis, atypical infection such as pneumocystis or cytomegalovirus, and drug-induced lung toxicity from chemotherapy agents.
Name 4 primary malignancies commonly associated with bilateral lymphangitic carcinomatosis.
The 4 most common primary malignancies are breast, lung, colon, and stomach cancers, as well as adenocarcinoma of unknown primary.
If the lymphangitic carcinomatosis has a strictly unilateral distribution, what primary tumor is most likely?
A unilateral distribution is most closely associated with primary bronchogenic carcinoma, resulting from direct retrograde lymphatic spread from ipsilateral hilar nodal disease.
Explain how most bilateral lymphangitic metastases are thought to arise pathologically.
Most bilateral lymphangitic metastases arise from initial microvascular hematogenous tumor emboli to the pulmonary capillaries, which then invade across the vessel walls into the surrounding interstitial lymphatics.
What is the key high-resolution computed tomography feature that distinguishes lymphangitic carcinomatosis from fibrotic interstitial lung diseases like usual interstitial pneumonia?
The key feature is the preservation of normal lung architecture. In lymphangitic carcinomatosis, there is an absence of architectural distortion, traction bronchiectasis, or honeycombing, which are hallmark features of fibrotic interstitial lung diseases.
Describe the anatomical significance of the polygonal structures seen on the computed tomography image.
The polygonal structures represent the secondary pulmonary lobules, which are the smallest anatomical units of the lung bounded by interlobular septa. Thickening of the lymphatic channels within these septa outlines their classic hexagonal or polygonal shape.
State the critical safety warnings and clinical prognosis for a patient with these findings.
The critical safety warning is that severe dyspnea can precede radiographic changes, requiring early high-resolution computed tomography to prevent diagnostic delay. The clinical prognosis is very poor, indicating advanced stage IV disease with a median survival of less than 6 months. The radiologist must immediately recommend referral to oncology and early integration of palliative care for symptom control.